Hello viewers, good evening everybody. So I welcome you all to this online class on the behalf of Indian Medical College. Dear viewers, in today's session we have our enthusiastic and energetic speaker, our beloved Dr. Asitava Roy, Professor and Head of Department Pathology from MGM Medical College with us. He is having a plenty of teaching and a practical experience behind him. He'll be taking a class on rheumatic fever and rheumatic heart disease. Good evening and welcome, sir. It's an immense pleasure to have you here with us.
Yeah, thank you, madam, for the, benevolent introduction. And hello and good evening, everyone. Today we will be discussing about this very important topic on rheumatic fever and rheumatic heart disease. Now, this is a topic actually which will be dealt with in each and every phase of MBBS, starting from pathology, and it will be dealt with again to some extent in your microbiology, as well as in medicine and pediatrics as well. So this is a kind of topic which will be dealt with in each and every phase of your MBBS career. Now, MBBS is such a kind of a professional course which actually cannot be dealt with in small domains. So it has to be integrated, and that is the reason. We have started integrating our subjects from now. Like pathology, we integrate our pathology subject with medicine, and likewise, all our clinical and paraclinical subjects, we teach it in a way of integration. So today, when we talk about rheumatic fever from the pathological point of view, I would also like to, touch upon the clinical case of a rheumatic fever. So let us start with rheumatic fever. So what would be the learning objectives for today's class? So at the end of the class, you should be able to describe the pathogenesis and clinical features of acute rheumatic fever and the rheumatic heart disease. You should be able to describe an Ashkoff body from the pathological point of view, know the parts of the heart affected in rheumatic fever and rheumatic heart disease, and also know their respective morphologies, and also learn about the long-term consequences of rheumatic heart disease. Now, how do you define rheumatic heart disease? Now, to go by the definition, rheumatic fever is an acute, recurrent, immunologically mediated, multi-system inflammatory disease. Now, these terms are important. Immunologically mediated. So it has some immunological factors associated to it, and it is an inflammatory disease. So these 2 points are important to be highlighted. And it occurs a few weeks following an episode of group A beta hemolytic streptococcal pharyngitis. So it has to be preceded by an episode of group A beta hemolytic streptococcal pharyngitis. So these are the 2 important points here. Now, before we proceed on to the detail of rheumatic heart fever as a whole, let us look on to a interesting case of rheumatic heart fever. Now, I have named this case as Prem, a boy with a bad throat who ends up with a broken heart. Now, Prem, a 12-year-old boy from a slum, presents to the pediatric OPD with fever and pain in the joints. Now, you mark the letters in red. The pain started in his ankle, then the pain subsided there, then the pain affected his knee. Now, presently, when he presents to the OPD, he has pain in the hip joint. On examination, some painless nodules on the skin were noted on the dorsal surface of his wrist. Now, when the chest was auscultated, cardiac murmurs were heard. And he also gave a history of sore throat 2 weeks back. Now, keep this case in mind, this guy, Prem, in your mind, and we will discuss this case once we are done with the whole rheumatic fever. When we have discussed the rheumatic fever, the pathogenesis, the etiology, everything, the morphology. When we are done with the discussion, we will again come back to this case. So just remember this case. I introduced this whole chapter with this case, and we'll come back to the same case when we are done with the chapter. So what is the pathogenesis behind rheumatic fever? So rheumatic fever, as I told you, it's immunologically mediated. And what kind of immunological reaction? It is a hypersensitivity reaction induced by group A streptococcus. Now, some antibodies which are directed against the M proteins of certain strains of streptococcus, they cross-react with the glycoprotein antigens in the heart, joints, and other organs. Now, if you see, now if suppose this is this streptococcus, and it has a antigen here. Suppose this has an antigen, and you have a antibody to it. Suppose this is the antibody. Now, if this is the heart, and you have the same antigen here on the heart muscle. Okay, so this same antibody will cross-react with the antigen here, because this antibody will think that the antigen here on the surface of the streptococcus is same as that of the antigen here on the walls of the heart. So these antibodies here will also cross-react with the antigens on the surface of the heart, on the walls of the heart, similarly in the joint and some other organs. So this phenomenon of cross-reacting of the antibodies with the antigens of the bacteria as well as antigens elsewhere of the other organs, this phenomenon is called molecular mimicry, because there is some kind of mimicry, and this mimicry is at the level of molecular, at the level of molecular level. So it is called as molecular mimicry. Now coming to the clinical features, how does the patient present to you clinically? Now when you come to these clinical features are defined by a criteria called Jones criteria. And this Jones criteria is actually has been modified, and this Jones criteria is now called a modified Jones criteria. And this was published in this journal called JAMA in 1992. Okay, and these criteria put forward by Jones actually has three parts: the required criteria, the major criteria, and the minor criteria. We'll look into it one by one. So what are the required criteria? The required criteria is evidence of preceding streptococcal infection. Now, how do you know that there has been a preceding streptococcal infection? So you have to have a raised anti-streptolysin O titer, or anti-streptococcal antibodies should be present in the blood, or you have to have a positive throat culture for streptococcus, a recent history of scarlet fever, or any of these two antibodies have to be present, anti-DNase B or anti-hyaluronidase. So if any of these are present, so you are assured that there has been a preceding streptococcal infection. So these are the required criteria. If these fall under the required criteria of modified Jones. Coming to the major criteria. What are the major criteria? Major criteria are migratory polyarthritis of large joints, carditis, subcutaneous nodules, erythema marginatum, and Sydenham's chorea. So these five. You have to have a migratory polyarthritis of large joints. Now when I tell you these criteria, keep remembering the case which I introduced to you when I started the topic. Keep remembering Prem, who came to you to your OPD. So migratory polyarthritis of the large joints, carditis, subcutaneous nodules, erythema marginatum, and Sydenham's chorea. And what are the minor criteria? Minor criteria are fever, arthralgia, any previous history of rheumatic fever or rheumatic heart disease, rise of some acute phase reactants. What are acute phase reactants? Like ESR, C-reactive protein, any evidence of leukocytosis, increased WBC count, or a prolonged PR interval on ECG. So these are the minor criteria. Now, when do you say that the patient is suffering from rheumatic heart disease? If you have one required plus two major criteria, you say that the diagnosis is confirmed. Or if you have one required, one major, and two minor criteria. So this is the dictum. So you have to have one required or two major, or one required, one major, or two minor. Now, for you all, at least evidence of previous history, previous streptococcal infection, you all will be able to remember. Fever, arthralgia, leukocytosis, this is easy to remember. This is nothing much to remember. But these five needs to be remembered, the major criteria. And how do you remember? So let me give you a mnemonic for it. And the mnemonic again is Jones. So nothing much to remember. The criteria is Jones. The mnemonic is Jones. How do you go about it? See, J for joints. So you remember migratory polyarthritis of the large joints. Then this heart, you remember carditis. N for nodules. So you get subcutaneous nodules. E is for erythema marginatum, and S is for Sydenham's chorea. So this is how you remember the five major criteria of Jones. J for migrate joints, that is the migratory polyarthritis, carditis, nodules, subcutaneous nodules, erythema marginatum, and Sydenham's chorea. So I guess this will help you in remembering the major criteria of Jones. Now, this carditis, which I mentioned in the major criteria of Jones, is actually pancarditis. Now, when I call it pancarditis, it means that it involves all the three layers of the heart. So it will involve the endocardium, the myocardium, as well as the pericardium. So there will be some changes in the myocardium, some changes in the endocardium, and some changes in the pericardium. So what are the changes in the myocardium? You will have presence of Ashkoff bodies and some presence of McCallum's patches. Changes in the endocardium would be presence of rheumatic vegetations, and changes in the pericardium would be fibrinous pericarditis. Now, fibrinous pericarditis is also called bread and butter pericarditis. That means if you put a lot of butter in between two slices of bread, and you try to separate the two slices of bread, so you will have those strands of butter in between the two slices of bread. So it would look the same if you have those, the fibrin exudate in between two layers of the heart, and if you want to separate the two layers of the heart, and so the appearance would be the same. So that is the reason you call fibrinous pericarditis as bread and butter pericarditis. Now the vegetations are nothing but some rheumatic vegetations are small linear warty vegetations along the line of closure of the valves. Now vegetations, again, it's again a different topic of discussion. Maybe I would like to discuss it when maybe I have a class on infective endocarditis, because it is again a different topic of discussion, and it is better dealt with in detail when we talk about vegetative diseases of the heart. So now maybe we'll discuss more in detail about Ashkoff bodies. So what are these Ashkoff bodies? They are nodules found in the hearts of individuals with rheumatic fever, and they result from inflammation in the heart, and they are characteristic of rheumatic heart disease. They were discovered by Ludwig Ashkoff and Paul Kiepel, and so they are also called Ashkoff-Kiepel bodies. They're spheroidal or fusiform and the size is 1 to 2 millimeter in size, occurring in the interstitium of the heart. And sometimes they may be even visible to the naked eye, not always microscopic. They're found in the vicinity of small blood vessels, occasionally also in the pericardium, and sometimes even in extracardiac tissues. Now, this is how they look like. Now, you see, they are also called rheumatic granulomas. Okay. Now, why? Because see, here at the center, if you remember the description of a granuloma from your inflammation chapters, so in the center, you have these collagen granulomas with fibrinoid collagen necrosis and surrounded by a collar of inflammatory cells. And these inflammatory cells are nothing but plasma cells and lymphocytes. Along with plasma cells and lymphocytes, you also have some histiocytes. And these histiocytes are nothing but two kinds of cells. One is the Ashkoff cell and other is a specialized cardiac histiocyte. We'll come to it, and that is Anichkov cells. So these are the two important cells, Anichkov cells and Ashkoff cells, which are present in this Ashkoff body. So this is a schematic diagram on the left side. On your right is actually a H&E stained microscopic picture of a rheumatic granuloma or Ashkoff body. So this is, here you can see these large cells here. These are actually Ashkoff cells in a rheumatic granuloma. Now, there are stages of evolution of these nodules in the heart, Ashkoff nodules. How do they evolve? They evolve in three stages. The first stage is early exudative or degenerative stage, where mainly there is edema of the connective tissue and there is increase in mucopolysaccharide ground substance. So because of edema, there is separation of collagen fibers in the Ashkoff body. And ultimately the collagen fibers, they fragment and disintegrate. In the stage 2, this stage is proliferative or granulomatous stage. So in this stage, actually, the granuloma forms. So here, the Ashkoff bodies proper, they appear. And here you see that the early stage is replaced by infiltration of lymphocytes, plasma cells, neutrophils, and characteristic cardiac histiocytes, that is the Anichkov cells, they appear at the margin of the lesion, as I have already showed you in that diagram before. And the third stage is the late fibrotic stage, where fibrosis appears, the nodule becomes oval or fusiform in shape, and the Ashkoff nodules become less cellular, the cells start disappearing, and they are replaced by a fibrocollagenous scar. Now coming to this cardiac histiocytes or Anichkov cells, what are these? Now Anichkov cells are large macrophages. They are macrophages which are present in the heart. And where are they found? They are found within the Ashkoff bodies associated with the rheumatic heart disease. Now they were named after this Russian pathologist Nikolai Anichkov. And the morphology is interesting. Now why is it interesting? They are also called caterpillar cells. Why caterpillar cells? Because in longitudinal sections, they show an ovoid nucleus and the chromatin is condensed towards the center of the nucleus in such a wavy rod-like pattern that it looks like a caterpillar. I'll show you pictures. However, on transverse section, it gives you a owl's eye appearance. Now, sometimes these Anichkov cells, what happens? They fuse to form multinucleated Ashkoff giant cells, like other giant cells that are formed in cases of other places where you get formed inflammatory giant cells. So here also, Anichkov cells may also fuse to form multinucleated Ashkoff giant cells. So look at this. So here at the center, if you see, the chromatin has condensed at the center of the cell in such a way that This gives you a wavy pattern at the periphery, and it looks like that of a caterpillar on the left. However, if you just make a transverse section of this and look at it from the top, how it will look? It will look like this. So on transverse section, it will look like this, and the appearance is that of a owl's eye. So on transverse section, it is that of an owl's eye, and in longitudinal section, it looks like a caterpillar. Now this was all about in the major criteria of Jones. Up to this was about carditis. Okay. Now coming to migratory polyarthritis. So what is migratory polyarthritis? It is a temporary migrating inflammation of the large joints. Now remember, it is about large joints only. It usually starts in the legs and migrates upwards. Remember, again, go back to the case, Prem. Where did his pain start? His pain started in the ankle. Then I told you that the pain subsided in his ankle and it came to his knee. Then again, his pain in the knee subsided. And now when he presented to you, the pain was in his hip. Okay. So it usually starts in the legs and migrates upwards. Coming to subcutaneous nodules. Now, your case also had subcutaneous nodules. Prem had subcutaneous nodules. Where did he have? He had subcutaneous nodules on the dorsum of his wrist. So let us see. These are painless firm collections of collagen fibers over bones or tendons. And they commonly appear on the back of the wrist, the outside of the elbow, and front of the knees. So here you see back of the wrist or dorsum of the wrist. This was where you got your subcutaneous nodules in your case of Prem. So these are again, this is a picture from another patient where you have these subcutaneous nodules at the on his back. Third point is erythema marginatum. Now, erythema, the term erythema means redness. Marginatum means the redness is mainly at the margins. If you look at this case, you see the redness is usually at the margins with clearing at the center. So that is why the name is erythema marginatum. This is a long-lasting reddish rash that begins on the trunk or arms as macules, spreads outward, and clears in the middle to form rings. Okay. This rash typically spares the face and is made worse with heat. Now, did your case have erythema marginatum? Prem, did he have erythema marginatum? No. Now, I told you that it is not always necessary to have all the criteria fulfilled to be stamped a case as rheumatic fever. I told you that it should have one required or two major, or one required, one major, or and two minor. But here erythema marginatum was not there in case of Prem. So this is another example of erythema marginatum. Next, coming to this Sydenham's chorea. Now chorea, the term chorea is, what does the term chorea means? Chorea means dance. Okay, so you all know the term choreography, right? So this term choreography also comes from this term chorea. So chorea means dance. So it is also known as chorea minor, historically referred to as Saint Vitus's dance. And it is characterized by rapid, uncoordinated, jerking movements, primarily affecting the face, hands, and feet. So there is rapid, uncoordinated, jerking movements. So these movements, they actually resemble they resemble dance, but this is actually not some kind of dance. But since they are not coordinated, they are some kind of jerking movements. of face, hands and feet, it looks like that the patient is dancing. So see the picture. In this picture, this is a classical description of Sydenham's chorea. So this results from autoimmune response of because of this group A beta hemolytic streptococcus, and this occurs because of destruction of cells in the corpus striatum of basal ganglia. And it was named after this British physician, Thomas Sydenham. Now, why does it occur? Because this offending bacterium interferes with normal functioning of the brain, which is responsible for controlling movements. So that is why this Saint Vitus dance or Sydenham's chorea occurs. Now, coming to prevention of rheumatic heart fever. I mean, like, how do you prevent? Now, always you know that prevention is better than cure. So prevention of recurrence is always achieved by eradicating the acute infection and prophylaxis with antibiotics. Now, this American Heart Association, it suggests that dental health be maintained and that people with a history of bacterial endocarditis, a heart transplant, artificial heart valves, or some types of congenital heart defects may wish to consider long-term antibiotic prophylaxis. So this is the recommendation by American Heart Association. So they say that people who have a history of bacterial endocarditis, heart transplant, artificial heart valves, or even some types of congenital heart defects may wish to consider long-term antibiotic prophylaxis. Treatment is usually by anti-inflammatory medications such as aspirin or corticosteroids. And individuals with positive cultures for streptococcus throat should also be treated with antibiotics. Steroids are usually reserved for cases where there is evidence of involvement of the heart. Now, monthly injections of long-acting penicillin must be given for a period of 5 years in patients with who have got one attack of rheumatic fever. Now, if there is evidence of carditis, the length of therapy may even go up to 40 years. Now, another important cornerstone in treating rheumatic fever includes the continual use of low-dose antibiotics such as penicillin, sulfadiazine, or erythromycin to prevent recurrence. Now, I'm just touching a few important points in the treatment of rheumatic heart fever. However, the detail of treatment would be dealt with with people from pediatrics and medicine. Now let us come back to to our original case, Prem, a boy with a bad throat who ends up with a broken heart. So the question usually now the pathology, the teaching of pathology nowadays is usually a case-based or a clinical scenario-based. Now, whenever you all get a question in your theory, it is usually a clinical scenario-based question. So you usually get a clinical scenario, and after that, which is followed by 2 or 3 questions which are to be answered. So the question, as you got the case scenario with this case, so the questions that may follow after the case are like this. So what is your diagnosis? So your diagnosis would be, since you got all the clues to the diagnosis, the patient had fever, it had the patient also had a history of a streptococcal, history of a sore throat 2 weeks back. The patient complained of fever with joint pain. Okay, he also gave a nice history of migratory joint pain. He said he had a and joint pain in the ankle which subsided. Then again, he had a pain in the knee which subsided, and now he has a pain in the hip. Okay, so migratory polyarthritis he had nodules. When you examined, he had presence of nodules, subcutaneous nodules on the dorsum of the wrist. So he had migratory polyarthritis, he had subcutaneous nodules. And moreover, when you auscultated the chest, you got cardiac murmurs. So that means he also has evidence of carditis. So you already have three major criteria fulfilled along with one required criteria, that is history of evidence of streptococcal infection. So what is your diagnosis? Your diagnosis for this patient is rheumatic heart disease. Now the next question might be, which clinical criteria did you use to arrive at your diagnosis? So your answer would be modified Jones criteria. And you say, in this case, what were the criteria did you use to arrive at your diagnosis? So in this case, the criteria that you used to arrive at your diagnosis were migratory polyarthritis, subcutaneous nodules, and carditis, along with evidence of previous streptococcal infection. That is a history of sore throat. Then you have this question, elaborate. So if you have this question, elaborate, so you now have to give the examiner all the criteria that are there in modified Jones criteria. That means all the required criteria, all the major criteria, and all the minor criteria. So here again, I would recall the mnemonic for the major criteria, that is Jones. If you have forgotten, so J for joints, migratory polyarthritis, heart is for carditis, pancarditis again. So all the layers of the heart will be involved. N is for nodules, subcutaneous nodules. E is for erythema marginatum, and S is for Sydenham's chorea. Okay. Now, what is the etiological agent behind the disease? So, group A, beta hemolytic streptococcus is the etiological agent behind the disease. Describe in brief the pathogenesis. So, you will have to then talk about the pathogenesis. What is the pathogenesis? Pathogenesis is, it is an immunological reaction. What kind of immunological reaction? It is a hypersensitivity reaction. And what happens is the antibodies of that react with the M proteins of the streptococcus will also cross-react with the antigens of the antigens in the heart, in the joints, and also in some other organs. And that is why this phenomenon is also called molecular mimicry. And that is the reason you see the joints are affected, the heart is affected. The next question might be, describe the morphological changes that occur in the myocardium associated with the disease. So the morphological changes that occur in the myocardium are mainly the presence of the Ashkoff bodies, how the Ashkoff bodies evolve in three stages, mainly the early exudative stage, then the intermediate proliferative stage, and third, the late fibrotic stage. So all those stages you need to elaborate, and you have to describe how a Ashkoff body looks like. So these are the probable questions in a case-based, clinical case-based question of rheumatic heart fever. Apart from this, you may also get short notes on a Ashkoff body, then on pancarditis, on the morphological changes in myocardium associated with rheumatic heart disease. So these are some, or you may even get a question on a short note on molecular mimicry in rheumatic heart disease. So that may be an interesting short note on coming for rheumatic heart disease. So that is again a interesting short note. So by now you know that a sore throat can lead to a broken heart. So this is a very commonly used uh, phrase that rheumatic fever licks the joint but bites the heart. Now, why so? See, this disease, rheumatic fever, why is it said that it licks the joint? It is so because the pathology in the joints is not that severe when it is compared to the pathology in the heart. So the heart is severely involved, or the destruction in the heart is much more than the destruction in the joint. So that is the reason it is said that rheumatic fever only licks the joint, okay, but it bites the heart. So this may even come uh, as a question like, uh, comment on the following statement: rheumatic fever licks the joint but bites the heart. Then you have to explain, as first of all you have to explain how the joint and heart is involved by the phenomenon of molecular mimicry, and then you have to go on to explain how the heart is involved, all the layers of the heart is involved in the it leads to pancreatitis. However, in joint it is only migratory polyarthritis because of rheumatic fever. So I think that's all for rheumatic heart fever and rheumatic heart disease. So if you are like interested, you may also go on to watch my YouTube channel Pathologym for more such lectures on the uh, subject. And for any other queries, any other questions, anything you want to know, this is my email ID. You can always contact me for anything you want to know. So thank you all.
Thank you, sir. It was a wonderful and informative session. It was so detailed and well presented. I hope that our students and the viewers would have got benefited by this topic. And dear viewers, if you have any doubts or any other clarification, you can just type them in the comment section below, and your queries will be clarified by our doctor at any time later. And sir, can you please stop sharing your slide, please? Thank you so much.
Yeah.
Sir. So let's wait for a few minutes for the queries from the viewers, sir.
Yeah, sure.
So meanwhile, we'll have some interesting talks by our expert in the upcoming session today. And thank you so much, sir, for the detailed explained presentation. And
yeah, thanks, Kavya. Thank you so
thank you.
much. Yeah.
Viewers, I hope you all enjoyed the session. So kindly share our YouTube channel and our Facebook page. You can also access the recorded videos, MCQs, and all the announcement of the sessions will be made in our Facebook page. So the upcoming session for today is the surgical jaundice at 6:30 to 7:30 p.m. by Dr. Ashwini Pujahari from AFMC Pune. As we don't have any doubts or clarification in the comment section, so we can wind up. Thank you so much, sir. Thank you so much for sparing time to.
Yeah, thank you so much.
Thank you. Thank you. We will see you all in the next session.